Lam Jam number 3. We're gonna hopefully talk about blood pressure a little bit today, to kind of frame a bit of an approach when thinking about blood pressure. I am particularly dumb today, having slept 2 hours, so you're getting the dumb version of me, but I have my little notes to keep me on track. And then, as usual, do kind of questions and whatnot throughout. So let's start off with what is blood pressure? Like, what's the equation for blood pressure? How do we? What are the two things?
You need a blood and pressure.
Correct, but mathematically, getting a little bit closer.
Systemic vascular resistance.
And what's the second thing? Which is corresponding to, Natalie's on it. What was it? Yes. Okay. So you have those two. This is kind of basic physiology. But it helps us understand kind of how medications work and how dialysis might affect this. Okay. So of the two, how do you determine cardiac output?
So
I'll give you a hint. It's another equation.
preload volume of each pump. Time
Yes, give me more.
plus how many times it pumps.
Boom.
Oh God.
Say. What are we looking for here? Oh, yes. So we call that stroke volume. So heart rate's an easy one to understand. It's how many times the heart contracts. Stroke volume is how many times the heart empties fully. So if we break stroke volume down, what is stroke volume? Now think about a heart. It's just a pump, the balloon that fills, and then it contracts and it empties, right? So what do we call the volume? What do we call the maximum volume? The volume at the end of what phase of heart filling?
Preload afterwards, something like that.
We'll get there. We'll get there. So what are the two phases of the heart cycle?
Loved up.
Correct. Contract and resting. What are those called?
Oh, gosh.
There you go. So at the end of the relaxation phase, that's when the heart is maximally filled, right? So that's called the end diastolic volume. And then it's going to be the difference between that and sort of the end of the systolic volume. So the squeezing phase. So if we draw a little diagram here, I'm going to try to draw a set. Make sense? Fill the bag, squeeze the bag. That's your stroke volume.
What's this sign? And
Oh, as it relates to. But you can think of it as a minus sign. That minus that equals stroke volume. Times heart rate gives you your cardiac output. And then your systemic vascular resistance is the other half of the equation. So if we were to focus on this physiology, I'm going to change colors for fun. What does this depend on?
Preload.
And if there's preload, there's also afterload, and what's in the middle?
Mid-load. Contraction.
Contractility.
The preload is what? Just the volume of blood that's there before the contraction?
Yes, the
Okay.
volume of blood that fills the ventricle. Boom. Contractility is the squeezing force, and afterload is the volume that you're squeezing against, which is, if you think about this physiology, you have a bag, you're squeezing the bag, and so your ability to get a higher stroke volume depends on how much you fill the bag, how hard you squeeze the bag, and what you're squeezing against.
It's like Starling's law almost, right?
It is exactly.
Yeah. Nursing school.
It's all kind of human blood pressure physiology comes down to this. So if we kind of look at these things, we can start to think about kind of how this impacts some of our patients and their physiology. So one of the things to look at is preload now depends on the venous return. If you have poor venous return, you won't fill the bag. Very simple. Afterload depends, especially in our patients, remember, it's not just as simple as what you're emptying into the volume of, you're emptying into a valve. What's the valve that the left ventricle meets immediately?
So I didn't.
LV goes into a big vessel, aortic valve. So your afterload actually will depend on whether or not there's any aortic pathology, or in some pathological states, there can be a left ventricle outflow tract obstruction. So all that means is that, very similar to AS, where you're pushing against a valve that doesn't want to open, you have some sort of hypertrophy in the septum or in the wall or in the tract somewhere as the blood is exiting, and you can't push against that. Now, bring yourself to dialysis now. Well, why is that a problem on dialysis? Not very good blood pressures. AS is very hard to dialyze. Very, very, very hard. It's one of the, I would say, relative or absolute medical contraindications to hemodialysis, because you cannot get around that. This is not an increased blood pressure thing. This is not an increased volume thing. You cannot open the valves, and you are fighting against a fixed valve. And then you have an entire extracorporeal circuit that you're trying to perfuse, but you can't improve cardiac output because your valve is stuck. So then you can't improve cardiac output, which means you can't improve blood pressure, which means you have a dialysis blood pressure of 90 and 50 and the patient not very good. This is why we care a lot about valve pathology. Now, we're very fortunate that most of the time we actually don't have severe aortic stenosis, or we have what we call hemodynamically insignificant or less significant aortic stenosis. And so they still have a portion of this equation, but we don't see it in terms of severe hypotension on dialysis, which can happen. So far, so good. Contractility is one where you're not going to really see this change on dialysis. There are a few things that impact contractility. Most of them are medications. And then clinically, where you might see it, especially our team here, is in the ICU, where patients are on different kinds of pressors, which can improve contractility. So this is starting to, in your mind, piece together when someone's blood pressure is low, why we might use some of those agents to bring you back here. Because remember, it all drives back to blood pressure. Make sense? So far, so good? Okay. See if I have any more things I want to say about that. Um, let's talk about this other side, this peripheral vascular resistance. I'm gonna make this a P because it's too many FVs and very confusing. Okay. So what is peripheral vascular resistance? How do we think about that conceptually? Not this one's not a trick. There's no equation.
It's the resistance.
Yeah. So the easiest kind of thing to imagine is a balloon. You blow into the balloon, you're blowing against some sort of resistance in the reservoir that is the balloon. That's going to depend on a number of different things. So what are some of the things that impact this?
AVM.
AVM as in?
It's not dialysis related, but like atrial, like that weird capillary thing.
Oh, the malformation.
Yeah.
A little bit less so. Think more simply, blowing into a balloon. What influences how you measure the resistance? So yes, give me a bit more along the line. Like I think you're thinking around the right path. So again, blowing into a balloon, there's some sort of resistance of the balloon pushing back. What's the balloon made out of? In this analogy, plastic, but in the body, made out of blood vessels. So the compliance of blood vessels matters. The other thing is, and you're probably skipping this because you're thinking it's intuitive, when you blow into a balloon, the resistance also is determined by how much volume you're putting in the balloon. You put a little puff in, it's not that much resistance. You can squeeze the balloon with your hand. You put a lot of volume in, there's a lot more resistance. And alongside this compliance of vessels is how the vessels behave. What can we do with our vessels in our body? And there you go. And then the last one, a bit of a less intuitive one, is the thickness of the blood, also known as viscosity. Which will impact resistance. So if you think back to our simple model, you're either blowing into a balloon or blowing down a tube, and these things impact the resistance. If you're measuring, if you put your hand outside that tube, and you're measuring how much pressure that tube was pushing out, all of these things will contribute to that. Okay, so before we get into kind of medications and thinking about this more on dialysis, why do we care about blood pressure? Yeah. Perfusion, particularly of what organ?
Heart.
Perfect. Tell me more about brain. No blood pressure, no LLC. Easy one. Tell me more about heart. No blood pressure, no coronary artery filling. No blood to the heart equals an MI. Goes back. Now, the tricky thing about blood pressure and the relevance is we assume that a blood pressure equals the organ blood pressure. We measure blood pressure peripherally, 120 and 80. We assume 120 and 80 is what the kidney is seeing. And the difficulty is each organ has its own internal system of regulating blood pressure. So sometimes what you measure is not what you seem to see. And this is evident in patients where we have really low systemic blood pressures. We measure them. I remember one of my first patients said that when I was a resident, this fellow was a gentleman, I think he was a history professor of some sort. His blood pressure was 50 on 30. Dialysis, off unit dialysis in his room, sitting up, reading a book, talking to me about history. And I was like, I seem to have a misunderstanding of how the human body works because I don't know how this is possible. But the true answer is perfusion in the brain is probably maintained in that patient by internal autoregulation. So similar to how the kidneys can clamp down and actually increase glomerular perfusion, we'll talk about that another day. You could do that in your brain. So it's a very interesting thing. And it really tells you that each patient has really their individualized blood pressure for their body. And everything's relative. So when you drop outside that ability to auto-regulate, you have more issues. Okay, so if someone's blood pressure norm is 100 on 60, and they drop down to 50 on 30, you will probably see them clinically look very different. Versus if their normal blood pressure is 140 and they drop into 120, you'll probably see nothing. And you see this all the time, actually, right? So it's going to be relative to what their body is used to. Okay, so this is about low blood pressure. What about high blood pressure? Why do we care about that? Who said that? Somebody said that. Stroke, yes. So again, brain can lead to a hypertensive stroke. And then we think about the other organ, lead to an MI. And again, it leads back to what's happening here. As this afterload increases, which is in this particular case that we're talking about, driven by high blood pressure, you have to work harder. Your heart must work harder to overpower that or compensate for that. And when you increase the demand on the heart, you start to mismatch the available fuel, oxygen, versus the demand for that fuel. So when you have that mismatch, it's kind of when you infarct or you're at risk of infarcting. And then there are other fun things that we won't see as much on dialysis, but you can have kind of shear stress related hemolysis. Hopefully we never see that on dialysis. It would be very dramatic. Yes.
For these people who are trying to recover and they're high.
Yeah, it would. Both of these in the extremes would impact renal recovery or the chances of renal recovery. Okay, so far so good. This sort of very general framework. All right, so we're gonna paint on top of this. Hopefully I can make it all fit. How we kind of address various things. So let's start here, volume. That's an easy one to understand. This one is directly controlled by what we do on dialysis. Take more fluid off, less volume, leave more fluid on, more volume. Feeds back into this equation and contributes to overall blood pressure. What's another way of controlling volume for our dialysis patient population, aside from hemodialysis? Yeah, diuretics. And which diuretics do you typically see in our people here? Furosemide. What does it do? What is it actually removing?
Sodium?
That's right. Sodium, a little bit of potassium, but for the purposes of volume, we'll focus on sodium and water. Follows the sodium, hemo removes both. And one other, I don't want to market this as a way of removing volume. One other way that volume leaves the body in our patient population. And there you go. So I'm not selling inducing diarrhea, but just to be aware that it can impact volume. So diarrhea is actually usually a lot more water than solute, but it does relate to volume.
Well, also the ones with ostomies.
Also the one with ostomies, yes. Yeah. So in terms of thinking about a blood pressure strategy and managing blood pressure in dialysis patients, we have dialysis as a reasonable tool. Diuretics, because there's diminished renal function and you need renal function to make diuretics work, it's less effective as a strategy. Starting a patient on furosemide, you would not expect a huge blood pressure decrease because you're not expecting a huge volume loss. The next one we'll talk about is, let me see what color I should use. Blood pressure as it relates to heart rate and contractility. What's an agent that controls that, or what's a class of medication that addresses this or affects it?
Beta blocker.
Beta blocker. So that's typically how blood pressure is affected by beta blockers. You can see that there's a lot more that contributes to blood pressure outside of these things. So even if you put someone on a blood pressure agent with a beta blocker, it may not actually impact true blood pressure. You'll see a heart rate decrease, but it won't affect stroke volume per se. And certainly you have to deal with the rest of the equation. One of the most biggest things in the rest of the equation that matters is looking at what's happening at the level of, do I have this color on the board? No, I don't. Here. So what are the types of medications or classes of medications that then affect this process, this vasoconstriction, vasodilation process? Remember, high blood pressure would be vasoconstricted, and then decreasing that blood pressure is causing it to vasodilate. What do you see our patients on? Either classes or meds. Which medications contribute to it? We talked about beta blockers, we talked about diuretics. You see a lot of patients on ACE inhibitors, right? That's a class. And then their cousin is the ARBs. And in our dialysis patients, where this will have the most effect is really in this vasoconstrictive process where they're chronically constricted and you're allowing them to vasodilate a bit better by blocking the pathway that causes the vasoconstriction. We won't get into it too deep, but generally that's how it works. You also have things that are directly vasodilatory. So nitro. You have hydralazine. And you have other medications that are less commonly seen in dialysis, but sometimes encountered, which is the phosphodiesterase inhibitors. Typically, men are on these medications for erectile dysfunction, but they do have a potential hypotensive property. So again, when you're assessing your patient and they have hypotension on dialysis, your first question is, are there any of these on board that need to be stopped or addressed? It's not always volume. Sometimes it's what are we doing to make the volume situation much worse? What other medications do you typically see us use? Sometimes we see alpha blockers. So that's your doxazosin, clonidine, terazosin, those are floating out there, less commonly used, but they're there. We see our calcium channel blockers a lot. That's amlodipine, nifedipine, and one other thing. What's the last blood pressure agent that kind of works along this pathway or axis? Some of our patients are on it. Along that pathway, spironolactone or an MRA. And the way that works is it blocks aldosterone. So again, you're blocking this entire cascade of ways of the body causing vasoconstriction and thereby having high blood pressure. In patients who still make reasonable urine, you could argue it also helps diurese. It helps get rid of some sodium. By and large, our population, we don't really have that bonus. Historically, traditionally, we do think of this as causing higher potassiums. So if a patient does make urine, let's say you have a patient who you know makes a liter of urine, you start them on an MRA because of blood pressure reasons, you then have to ask yourself, is their serum potassium going to be a little bit higher? And sometimes it's something to watch out for.
It's a potassium diuretic.
Yeah, allows the body to keep it. Okay. One other thing on dialysis that we can do to affect this process. We don't normally do it, but technically you could do it on dialysis. How could you? Temperature. And why? Why it works. Yeah. So technically, you could do this. Now, we run patients usually at or slightly below their normal temperatures to forcefully cause a bit of vasoconstriction because we know that heat is released through the dialysis process. And if they just vasodilated and kept vasodilating, we would have blood pressure problems on dialysis. But the converse could be true if you have someone who is quite hypertensive all the time. You could actually run them at a higher temperature on dialysis. We don't normally do it. But again, just explaining the ways of doing it because most of our patients go hypotensive. Yeah. So the ones who have fairly intact hemodynamics on dialysis, you could run them at their own temperature. Could make an argument to run them a little bit above. Again, you have to be mindful of what the experience is on the patient side. They're going to feel warmer, which may not be the most comfortable thing. Splash might be comfortable. Okay. Any questions about any of this? What about this little guy? What can we do / do we do in our delivery of care that can impact viscosity? That is not a pathological process. Heparin? Sort of. Think thickness of the blood throughout the whole body, not as it pertains to dialysis, which is what I think you're thinking of.
Yes. The higher your blood sugar is, the thicker it is.
No, because it balances with water. What a medication we give. A medication that we give to maintain a certain blood parameter.
Blood thinner.
Not a blood thinner. Remember, it's about the warfarin is an think of it more as an anti-clotting agent. Yes, we call them blood thinners, but an anti-clotting agent. We're causing thicker blood. Thicker, like your hematocrit goes up.
Saline?
There we go. ESA. So this is why we care about maintaining individuals within some sort of set range, because as they go up, their viscosity goes up and it can drive blood pressure. In fact, that is one of the side effects of an ESA, right? And you will notice in some of our patients who are running at much higher hemoglobins than desired, they have higher blood pressures versus those who are running at a hemoglobin of 95. We have a few probably that are running at 130 and we're just holding and waiting, and they have higher blood pressures because of that.
Based on not volume, but viscosity.
Both. Everything, blood pressure is based on all of this, but this definitely plays into it. So pathogenically, if we take ourselves outside the dialysis world and we look at what causes higher viscosity, you have individuals with polycythemia vera. So this is an abnormal bone marrow production where they just pump out lots of red cells. In very thick blood, they start to have high blood pressure, they start to have strokes, they have occlusions that happen. You can also have paraprotein processes that cause a lot of protein production that thickens the blood up. So there's other processes that we don't normally see here, but contribute to blood pressure in the same way. Does that make sense? Okay, any questions on that or on any of this? Okay. I don't have a brush or something to clean the board with. Do we have a cloth? Somebody, thank you. Okay, so I'm gonna get rid of most of this. Get rid of this. So we'll segue from blood pressure into thinking about, that brush was terrible. Go away. So oftentimes this is something that we get asked in the community. We get oftentimes a fax, we call them RFAs, a request for advice, and it's usually around goal weight. Here, you guys usually come up to me or whoever and ask about goal weight. And a lot of times the response is either because the blood pressure has been doing something funny. Usually, from your nursing standpoint, it's usually because the blood pressure has been low. So we're struggling on dialysis. Very rarely do I see you approach the NEF or me because the blood pressures have been high and you want to assess goal weight. Usually then you approach saying the blood pressures have been high. So this is just to point out in your mind, you still want to link the two. And you want to, from a nursing assessment standpoint, ask the question, are we getting to goal weight? One, if not, why? Two, is the goal weight appropriate? That one's a hard one, because how do we define the perfect goal weight? What did I say last time?
Where you're not, the patient's not pissed off at you.
Patient hates you minus a little bit.
Yeah.
There you go. So that's the ideal goal weight. Patient hates you minus a little bit. Okay, so that you can imagine that number, that number's hard to just like pinpoint, right? It's hard to just say, oh, your number is 45. But there's some subtle clues as to whether or not the current goal weight might be appropriate. And one of them that I use is very simple is, when was it last kind of formally reviewed? Hasn't been reviewed for 6 months. I don't know about you guys, but a lot of things change in my life in 6 months. So
How often do you think she
depends on the patient.
like 1-2 months in general?
No, depends on the patient.
No?
Variable answer. There's no, I think, right. I think the fact is to be, pragmatic, but also efficient. The review of the goal weight should happen regularly to at least verify we're at the right place. 50 was right, 50 is still right. Check. And that's, it kind of proves that we've done that. Sometimes that's done, but you don't see a change in the DOHP, which is difficult then as a team. Even for myself, I don't know, is this something we were okay with over the last 6 months the whole time? Or has it just not been thought about for the last 6 months? Because either could be true. So this is an easy, subtle one.
My question is, why isn't everyone on like a range dry weight? Because like I don't weigh the same every day. So like why are a lot of people not on like a range? I kind of understand with the range, as long as it's not like a drastic.
Yeah. So in my practice, what you will see is I provide a range. The range is very simple. It's 1% of your goal weight. And the rationale behind that is you fluctuate day to day. Now that's just style points. There's no right or wrong way. It's my recognition that I would like that physiology reflected in the order. But you can imagine you write 87.5, there's a plus minus 0.5 there somewhere. You just have to apply it. So it's just pure style points. You'll see different Fs do different things. I don't think it's right or wrong. The second reason I like to do it is I like to give my patients some element of control, because you have so little control in our world that if you could at least say, how do you feel today? Do you feel like we should go for the lower target versus somewhere in the middle versus the higher target? At least they have a say, right? So it's, for me, it's symbolic more than it is specific to, like, you know, nursing, but it also reflects the fact that you guys as clinicians also have some ability to assess that the goal weight is, maybe we're going to aim for the lower one today, or maybe they've been more symptomatic. And you do this, you challenge patients without an order, right? Because you're like, okay, you're coming in the low end of your target removal. We're going to add a 0.4, see what we get. Happens all the time. So again, just reflects that process. But you will almost always see me do this up to a minimum of 0.5, because I think our scales don't really capture changes more nuanced than that. So if you're a 40 kilogram person, still going to give you a 0.5 range, if that makes sense. So going back to goal weight and figuring out whether or not it's appropriate, you might say, well, the goal weight has been what it is, and there's been hypotension. This is why I'm concerned. Then you have to go back and say, well, are there other things driving the hypotension? Because sometimes as we probe a patient down on the goal weight, the blood pressure improves, then it goes low. And actually at that time, we have to say, should you be coming off your medications? Because we've now controlled the volume on dialysis, and it's time to reassess the antihypertensive strategy. So everything is a strategy. You think of it not in isolation. It's not just a goal weight. It's not just volume. It's a strategy. Potassium is a strategy. It's not just the K-bath, right? It's diet, it's binders, it's compliance with dialysis, it's time on dialysis, it's pump speed, it's everything. So think of it more in that kind of range. And then the last kind of thing I look at when you bring that issue to me of goal weight is, when was the last time at goal weight? Because I will level with you. One of my pet peeves is getting a request to reassess goal weight, and then 2 runs ago, they were at their goal weight. And we're asking for a reassessment to relax goal weight. It's not that I don't want to relax goal weight, is I want to make sure that I'm doing it for a good reason. So if you're meeting your goal weight recently, then we might be drawing an abnormal conclusion based on one bad run. We all seen this. 1 in 10, 1 in 12 runs are garbage. It's therapy. It's not your fault. It's not their fault. It's just, we got crappy dialysis. Sometimes it's nausea. Sometimes it's blood pressure. Sometimes it's LOC. Sometimes it's lethargy. 1 in 10. That's a general rule of thumb. So if you were recently at your goal weight, really within the last week, within the last 2 weeks, I question whether or not we have to relax the goal weight, or whether or not we're not able to take the fluid that is there with the current dialysis we're providing. What is the answer to that? Yes. Not a practical answer, but it is an answer. So you will see me do this, where I suspect now that the goal weight is not wrong, but we are unable to achieve the goal weight due to other factors. So then we look at, are you on blood pressure medications that are preventing your blood pressure from responding adequately when we try to get the whole volume? We can't get the 3-liter target. We think the goal weight's right, but we can't get the 3-liter target. Or is it a refill problem? We talked about this last time. We need time to refill, and maybe we're not gonna get it done on 4 hours.
No, we find frustrating not, nothing to do, but the patient with all the like dilated gravel, whatever, you know, the fluid's there and they're fluid overloaded, but it's reading 80/40 the whole time. After you give it, you're like, take it, not take it.
So I'll repeat it for the viewers. One of the nursing frustrations is patients who are on medications that may drop blood pressure, like hydromorphone or sometimes gravel or dimenadronate, and then being limited in terms of the therapy you can get because of those things. Unfortunately, it is part of our world. And the answer is the same with respect to goal weight. Is the goal weight correct? That's the first question. And if it is correct, or if we haven't proven that it's incorrect, then do we need to change the strategy? Is it 4 times a week? Is it shorter runs 4 times a week? Is it an extra run to catch up once a month or whatever? We have patients like that. They had a big salty meal with their family over the weekend. They put on a lot more fluid and we can't get it. We've never been able to get it, but we've not had the problem until now. It's because they didn't put that much on. And now we can't get it without them crashing or cramping or feeling nauseous or whatever the thing is. So that's where you go, we should do an ISO-UF. This is anecdotally significantly more well tolerated. Less symptoms, blood pressure is a lot better. We can talk about why later or on a different session. And it might help you reset. So we're aiming for 55, we're hovering at 60, we can't get to 55 in one run. And then by the time you come back on Wednesday, you're back at 60, or you're back at 59.5. You're not going to get down to 55. But if you plug in an extra run, you might bloop, get a lot closer, right? So it's kind of this yin and yanging, never getting down to there, where getting down to there might allow you to reestablish what we're accomplishing on dialysis.
I have a question, and it's an anecdotal thing that maybe you know the physiology for it, but there are some patients that actually, if they're pulling too much fluid, they'll go severely hypertensive. Is that a compensatory mechanism? Because like their RBV will be like super low and they'll be severely hypertensive.
Yeah, that's a great question. Yeah.
Right? Yeah,
And
we have
it's
a couple.
worse and worse.
Yeah,
Yeah.
and then a lot of them have to like pull more fluid, but then they get more symptomatic the more fluid you pull.
Yeah.
So
that's a great question. I'll repeat it so everybody can reference it. But in some patients, there is an idiosyncratic response to fluid removal and their blood pressure goes up. And there's a couple reasons why this could be. One is if volume removal is actually optimizing the cardiac status, and as you take the fluid off, the heart is actually operating within that more powerful range. Remember, if you're contracting out here, you're not as powerful. You cannot get the squeeze. But if you remove the fluid and you're here, and now you're contracting, you're in your power range. So that's one, because remember, that is how we get blood pressure. 2, and this has never really been measured and shown, but there's very likely in those patients, the dialytic removal of endogenous vasodilators. So they normally make substances that keep their blood pressure under control, and we take it and we check it. So their blood pressure goes and jacks up. So that is a function not of fluid, but of dialysis time. So they're few and far between, but there are patients where you dialyze, and as they go through the run, everybody else's blood pressure comes down, every other patient, but this patient's blood pressure goes up. And that's that patient where you're probably dialyzing off an endogenous vasodilator. It's like as if they had a nitro patch on, you took it off, and you go, wait a minute, why'd your blood pressure go up? Why took the nitro patch off? So it's probably that. Those ones are very difficult.
their RBV is really low. So
because they're not refilling, and it's in those patients, it's not a fluid problem per se, unless they're overloaded. It's a function of a removal of this substance. Now they're not common.
Like if you're wrong to write 230 over 125,
And you have-
for 4 times in a row.
Mhm.
You know, and we're like, oh, probe, like,
Mhm.
we just keep going, I don't know.
But then you give their blood back and then they're not hypertensive anymore. So it's just, you seen that too?
Better.
Yeah.
Yeah. Or you bolus them and then it's better.
I don't know, we just ignore it and switch through, like,
Yeah, you have to set parameters for that treatment. So maybe it's actually you're doing less dialysis, 3 hours, 3.5 hours instead of 4 for those individuals, or you recognize that their true blood pressure is when their cardiac status is more optimized, and you actually need to think about treating that and then keeping them in that range. It means that you're oftentimes quite out of that range, and that's why that contractility is not very good, not contributing to blood pressure. But then every time you dialyze it back into their optimal range, you suddenly get a restoration of all of this. So the short answer is it's tricky. That's the short answer. Those should be the exceptions. By and large, 85% of patients you should see as you take fluid off, their blood pressure goes down. They are behaving very normally. And then
young guys, even they call
Mhm. Yeah. Some of those characters are extremely fluid overloaded. Extremely. Yeah. Any more questions about goal weight and blood pressure specifically, and the kind of the interplay between the two?
I think we talked about it, but another nurse who's not here, they wanted you to touch again of minus 0.3.
Probing. We can talk about probing. Yes, probing we can talk about. Oh my God, this is a terrible. Just smearing. Goodness. Okay. Thank you. So we talked about a little bit about this last time, but it's worth reviewing because it's a fairly common thing. But basically, goal weight probing is a process by which you can sort of seek that ideal goal weight, but in a gentle way. Because if I took Cheryl and I said, your ideal goal weight is, I'm gonna make it up, 65, but you're currently sitting at 70. If I went from 70 to 65, I would guarantee you I've crossed into that I hate you zone. And I don't wanna do that. So we're gonna use this example, say, we think it's 65 kilograms, but we're currently at, let's say, 68 kilograms. So how this works is we kind of take small increments and you're getting them down to a smaller baseline each time. So let's say we do dialysis, we get this patient to 68 is their post weight, which means check, we've accomplished and achieved our goal weight, pat on the back. But you still think and you can see they're carrying a lot of extra fluid. And instead of gunning for it and saying, well, the next run, when you come in above 68, we're going to go for 65. Because if the next run you come in at, let's say, the intradialytic weight gain is 1.5 liters. So they're coming in at 69.5. The difference between 69.5 and 65 is 4.5 kilograms liters. That's a lot. That's a lot to be for most patients. And if you targeted 68 again, that would be a 1.5 liter removal. But if you probed down slightly, so you drop them by, again, 0.5%, something where you really won't feel it that much, and we say our probe is here is going to be 0.3, then you're going to go for 67.7, which means your target is 1.8 liters. That's more reasonable, right? More reasonable. Don't hate me. You don't hate me yet. We're getting closer. We're chasing the edema. Now we take this process and we say, we take what you accomplish. So let's say this patient is on BVM. We'll just use that as an excuse because otherwise the numbers don't work up. So you're coming in at 69.5. Your target is 67.7 because it's 0.3 less than the last achieved goal weight, and it's a 1.8 liter target. So far, so good, minus the rinse back, blah, blah, blah. And then your BVM goes and takes 2.2 liters, which means you actually will come off at 67.3. So you then come off at 67.3. And if you went back to the probing equation and took 0.3 off 67, you'll see that would be 67.4. But you've already achieved that. You don't, why are we, let's just skip the step. Let's take the post weight that was achieved, and then your next target would be 67. And again, intradilatic weight gain of 1.5, again, theoretical. So that means you're coming in at 68.8. And then we're going to go for 67, 1.8. Again, you don't hate me. That's what we're going for. We don't want to be hated. And then eventually, if you repeat this enough times, you will get to what you think is close, which is what you're hoping for. This is based on clinical assessment. It's based on blood pressure. It's based on the tolerance of dialysis, all those fine little things that we integrate. That's how we're going to get and determine this. Now, sometimes our guess is wrong. Maybe it's not 65. Maybe I think there's 3 liters in the legs, but there's not. But what you will see is that you will start to not accomplish the same thing. So let's say we take this forward and we go, it was going to be 68.8 down to a 67 target. We got that. Next one, we're going to come and go after a 66.6 target, right? Because we're 7, because we're minusing 0.3. And let's say we get that, just for argument's sake. Then the next one, we're going to go to a 66.4 target. But instead of getting this target, for whatever reason, you come off, and you come off at 66.6. So you go, well, it was supposed to be that, but it's this. But we can do it again. We can repeat this process. We can set our next target at 66.3, right? So we set the next target at 66.3. Again, blood pressure dips a little bit. They go into minimum for 15 minutes. You don't quite get there. You get off at 66.5. And then you go, well, normally in my practice, I like a good 5-run probe. Because again, if you're working with this, that's about a 1.5 liter. If you're going straight, like, and when I say straight, it means you do not over accomplish. So a 1.5 liter change is a good trial of volume status change. But you could technically go, you can go for 10 runs if you want, or you can go until a certain number. That one's a bit more blind because you assume your number is correct. So let's say we're down here, and we have one more run to go. It's number 5. So you say we did not accomplish 66.3, we got 66.5. We will go for 66.2. And then what you accomplish there is 66.4. So you didn't quite get it. But what you're starting to see, or what you should start to see in this little pattern, is you're starting to narrow where our target goal weight is. You're starting to look almost at the same number every time because you do not accomplish. You cannot probe further. That is a very gentle way. This is a gentle way of goal weight seeking, if you want to call it that, where again, you're testing where that patient is going to dip into the zone of, I hate you, and you want to back off just a little bit. And remember, as you're doing this, the nuanced part or the elegant part here is, do I have to back off on my blood pressure agents? Because if blood pressure is the limitation here, and you're on a whack load of agents up here because you came in and you started dialysis and you were on 5 blood pressure medications because your blood pressure is out the yin yang. But as you accomplish a lower blood pressure, do I have to peel that off to allow me to find the goal weight? And this is where, again, you guys, like when you're reviewing, you're like, hey, these blood pressures seem to be getting better. We're not there yet, but they're getting better. But Joe is still on 4 blood pressure medications. Like, Are we looking into the future gonna get into a place where we're gonna hit a danger zone, where we will not be able to accomplish therapy or probing or whatever because of blood pressure? And so this is the principle behind go weight probing. It is take what you accomplish, use that as your next target minus a slight small amount, and then repeat that process until which point it becomes very clear that you're not accomplishing any more based on who that person is and where they are at that point in their clinical journey. Make sense? Other questions? Yay. Okay, you're welcome.
I think we're good. Thank you, Ash. Yeah, thank you very much.